Why is it not getting full screen? Okay. These competencies are all in the NMC website. The MMC website has a topic which we have to cover for a daily, and 1 week is going late, and it's our schedule is all displayed on MMC. The competencies you will find it in NMC website. Okay, these competencies are what you have to know as a at your level. That is, classify and describe the blood group system, enumerate blood components, and describe the clinical use. This second topic, I would say, we used to study when we are preparing for PG because this is one of the favorite question of for the PG entrance exam. Blood grouping as an OSPE questions, you get a lot of questions. I'll be showing you some pictures in between in which the blood group you have to identify. This is a short OSPE question for you, the identification of blood group. I'll be describing about transfusion reaction, and in 2 to 3 lecture today, you'll have a lot of case history on the transfusion reactions. Then the enumerate the infections of blood transfusion. You get short note on this a lot of times, and this the autologous transfusion is a new addition. I have taken this lecture last year also. This as per NMC, this is a new addition. Okay. So we all of you, I believe, know your blood grouping. I don't know whether it was conducted in physio during COVID times, but we had in physiology blood grouping of all our. We used to conduct blood grouping of all this one, and more so now. If you need a driving license and all, you need to know the blood group, and all of you must be knowing your blood group. The most common, which can be A, B, or O. So, a brief about history. Carl Landsteiner was the first person who discovered the blood groups in 1901. It is based on the membranes of red cells which contain the blood antigens or agglutinogens. There are several types of blood groups like MN system, a lot of their Kell, Duffy, but major adult level will be doing about A, B, O, and RHT. That is the main thing I'll be teaching today, but there are several other minor blood groups which are also important. Transfusion medicine as such has formed a separate branch now, but covering this in one lecture, so I'll be focusing mainly on the main groups and which is important at your level. Okay, so this follows the Mendelian rule. This all of you must know that how a baby gets the blood group depending on the blood group of the parents. Okay. The most important, as I've said, is the ABO system and RH system. I believe you must have done hemolytic disease of the newborn, which is also important. These are other important systems. They are formed in minor group, that is like Kell, Kid, Duffy, MNS, and Lutheran. These are all other. And Duffy, I believe you must have been taught in malaria that P virus infection is protected if there is absence of the Duffy group because the P virus enters to the red cells through this. They are the of the ABO blood group systems. The four major groups are A blood group, B blood group, AB, O. In A, there is antigen A, and in B, antigen B. In AB, antigen has antigen A and B. In O, there is no antigen in them. Okay, it is found in other tissues like the kidney, liver, and the lung. It is controlled by the allelic gene A1, A2, B, and O located in long arm of chromosome 9. Along with that, there is a H antigen which is located on chromosome 19. This is actually the precursor of A and B. Okay, if you this adding of the antigen on this H antigen makes a patient blood group A or B or O. Okay, so this is actually added to the proteins or the lipids in the red cells. The substrate, which is the H molecule, is the glucose, and if A antigen has to be formed, you add an acetyl galactosamine, and B antigen is the galactose is added. The A and B gene codes for transferase enzyme, and this adds the specific sugars to the RBC membrane. So we have a molecule that is H substance, and if the H substance we have the galactose or N-acetyl galactose, you have the addition of this substance forming to the blood group A, B, or AB. If A N-acetyl galactosamine is added, the person will have A. If both is added, the person will have AB, and if galactose is added, the person will have B. While in the other case, these two substances or antigens are not added, so the person will be blood group O. So why do we have NPA and NCP? They are not present in the newborn and develop in the first year of life. This mainly is because of the exposure of the plant bacterial, viral antigen which provokes the response. This is the table which you need to know because this is what will happen if you want to know the blood group of the patient. Okay. So if a blood group is A, a person with a blood group A will have A antigen on the red cells. The serum will have anti-B. So the genotype will be AA or A naught. In blood group B, they will have B antigen on the red cells and antibodies in the serum will be anti-A, and the genotype of the person will be BB or B naught. In AB, they will have both the antigen, that is A and B, and they will not have antibodies in the serum. They are also known as universal recipients. And O, they do not have any of the antigens in the red cells. However, they have anti-A and anti-B. This is a pictorial depiction of what I said. So in the red cells, if we have this A antigens, the person will be blood group A. If it is B, the person will be blood group B, and AB will have both the antigens, that is A and B, while the O will not have any antigens on them. The corollary to this, the antibody which is there in the plasma, A will have antibody B, B will have antibody A, AB will not have any antibody, while O will have antibody which is A and B both. What is the nature of these antibodies? They are major groups present on almost all the individual when the absent and is absent. They are of IgM type, which is a pentamer. So they are large cells and they do not cross placenta. If you compare this with your RHD, they are IgG type and they crosses the placenta to cause hemolytic disease of the newborn. Okay. They can be IgG type also in some minor blood group, as I said, Rh and Mn type. They react at body temperature if it's of IgG type and readily cross the placenta. What are the methods of detection of blood group? Okay, so how do you detect the blood group in such patient? Okay, we detect it by serology with the ABO antigen man method used in blood transfusion centers and in hospital blood banks. It composes antibodies that are specific at detecting a particular antigen on the red cells or along with the known red cells. If they have in the blood bank, they have pooled red cells which are A, B, or O, and you react with the serum of the patient to know what is the actual antibody which is present on them, because we know that the person with blood group A have antibody B. Okay, so today will be precautions what has to be taken. We have to test both the cell and the serum. So that is the forward grouping and reverse grouping, which we'll be talking about. And it should be done at a room temperature or lower. It should be done be properly labeled and results should be recorded immediately after observation. If there is hemolysis, it is taken as positive result. There are various techniques of detecting ABO blood type. We can use a slide or the tube technique. These two procedures will be demonstrated today by a resident. We can also do with microplate technique or diamond ID microtyping system or glass microbead method can also be used. This reagent anti-A, anti-B, this picture you must have seen a lot of times while detecting your blood group. So I have talked about forward grouping and reverse typing, reverse grouping. What are the two main difference between this? In forward typing, we use the patient blood and that of a serum which is contains this, which has the anti-A, anti-B or anti-AB. So in this reaction, we know what blood group the person has. In reverse typing, we are doing the opposite. We are taking the patient's serum or plasma and mixing it with a known red cell suspension of a type or A, B, and O. So the reaction will confirm which antibody the patient has or the person has in the blood. In the forward, we are detecting the antigen. In reverse, we are detecting the antibody. Okay, this is what is forward grouping about. In and they have the where putting antibody A to them, the person has antigen A. So they will react with this and form and agglutination in them, and we know the patient or the person has blood group A. In B, this is what will happen. It will react with the anti B because they have antigen B in them. In O blood group, we do not have any antigen, so they will not react with any of the antibody. In AB blood group, they will react with both. So this is what one of the favorite OSPE questions will come as. What if the picture is shown if there is a reaction with the anti-A, anti-B, or if it's with AB. So what will be the blood group of this? This is the forward grouping and this is the reverse typing. In reverse typing, I have said A cells, B cells, or O cells are used. However, in forward, we use the antibody. So, what would this person be having? Because it is reacting with anti-A and anti-B. What is the blood type of this person? Anyone? Yes, you're right. This A blood group. So I have yes, it is A blood group. You all are right. So I have a table of this. Okay, this is the answer. This is what is asked frequently in any of your OSP. Like what will happen in if it's a blood group. So you just have to remove all this, and if you show with this what is A, B, or O cells which is reacting with this, what you have to remember in this is that the first group is your forward typing and the next is your reverse grouping. So this is reacting with the serum or the plasma. Most frequently, and even in log now, they use a tile method. It is a huge white tile, and they react with them and see the blood group. They are doing both the forward and the reverse. And depending on which antigen is present on the person, we will be able to determine the blood group of the person. Okay, remember this because this is frequently asked in the OSPE. Okay, coming to Rh blood group, Rh factor is named for the rhesus monkey, which you all know, and is found in red cells. This is just a revision of what you have done in your hemolytic disease of newborn. They have C, D, E, and most important is D. Uh, they are no naturally occurring antibody against Rh antigen. How do an Rh positive, a negative person becomes Rh positive? This is mainly implicated in gynecology, mainly when you deal with a person who or a pregnant female who is Rh negative. If the person has had a exposure to the Rh positive red cell has been transfused with that, or the person the husband is Rh positive, or from the fetal blood to the maternal blood. And entity belongs to IgG. Why IgG is important at this level is because you have to know that they are smaller and they cross the placenta and gives rise to the protein manifestation of hemolytic disease of the newborn. So this is what happens in Rh incompatibility, and more so, you, as I said, you will come mainly in gyne ANC visits when the mother is Rh negative and the father is Rh positive. The first baby is usually uh, normal in them. So Rh negative and Rh positive, you have the fetus in which the first pregnancy is if it's normal. Problem starts when if it's an Rh positive fetus and there is a feto-maternal blood which occurs during delivery and the person gets sensitized and they have not received any uh, anti-D during this time. What happens in them is that the second baby lands up with hemolytic disease of the newborn. This is just a revision. And what is important in them is that you have to administer the anti-D immunoglobulins to these Rh negative mothers on the pregnancy. Even if there is an abortion, also you have to administer them because the feto-maternal blood is what is leading to the cross mixing of the Rh positive blood group of the baby to the Rh negative blood group of the mother. Okay. You all must know that the most common blood group worldwide, India, is mainly O, followed closely by B positive. Okay, and so there are some other rare blood groups which are known. Okay, so let's touch on this, some rare blood group. And this really, you will see this blood group in when I touch about autologous transfusion. And I don't know if many of you have seen this movie. There is a movie on Bombay blood group in which the villain was caught because of this blood group only in a blood bank. So Bombay blood group was first reported in 1952. Absence of A, B, and H antigen in the red cells is there. It is a very rare blood group, and the H antigen is not there. A gene is not there. So H antigen, which I have showed before in the formation of the AB and AB or O blood group. So there is no substrate for sugar transferase. They can't make any antigen A or B, and instead of that, anti-H is formed. So they appear as group O, but they cannot be transfused with any blood group O because they have anti-H. So they will react even with O negative red cells. Okay, so such patients have anti-A, anti-B, anti-H, anti-H antibody, and they will have uh, hemolysis even with O blood group. Okay, and this patient has to be transfused only with the Bombay blood type. What such patients usually do is it is very rare. They usually taken blood out in case there is an emergency need. They are stored in the uh, blood bank so that they can be transfused to them later on in case there is any road traffic accident or the person has some hemolysis. So as I've said, it was in some of the movies, Kahani, if you remember, that the patient was caught because of this blood group because he had to have frequent phlebotomies to donate his blood so that it can be saved later on. Okay, Coombs test, I believe all of you know about Coombs test because it was discussed in hemolytic anemia. And Coombs test is also important in transfusion medicine. Why? Because it is one of the methods of determining your blood group and also for your indirect testing or maybe for your minor blood groups also. So I need not go more into this because this has been discussed all. The principle also, you know that IgG, they're incomplete antibodies, so you have to add a complete antibody, that is anti-human antibody, to combine this immunoglobulins, this incomplete antibody, to form a visible agglutination or clot formation. Okay, what are the uses? Is it is direct womb test. I will use in mainly are direct in detects antibodies in vivo. Okay, this is the test. I'll not go main into this because I got to know this there. Yeah, this is what it is used. It is used mainly in transfusion reactions and drug-induced red cell sensitization, autoimmune hemolytic anemias, and hemolytic disease of the newborn. We do a positive direct DCT, direct wombs test. Coming to indirect wombs test, this is when you have to test the serum for the presence of the antibody. Okay. This also, I'll not go much into this because this has been done. What is the application? This is what is I was mainly concerned about: antibody screening, cross matching, antenatal antibody screening, and determination of RBC phenotype using known antisera. For this is the application of indirect Coombs test or anti-human globulin test. So DCT is also part of a component of your transfusion medicine. As I've said before, this is what is commonly asked in your postgraduate exam. And it's a demand. You must have known during COVID, a lot of people has been asked for plasma, to donate blood and to take out the plasma. Plasma transfusion was one of the things which was there in COVID. However, recently ICMR has removed it, and there is no role of this plasma in the COVID. But last year, during first peak, there was a huge demand. Even during second peak, a lot of WhatsApp messages you must have seen, in which they had asked for the recovered COVID patients to donate so that it can be used. But plasma as such has not been used. So if you are asked in Viva, mainly because of COVID, and you know about the uh, transfusion, this can be the thing. And what are the blood components that you know of? What is red cell concentrate, what are WBC reduced concentrates, and what is FFP, okay, fresh frozen plasma, and what are cryoprecipitate. That is what I will talk about in blood components. That is separating the components of blood in one and then transfusing it to each patient, which is the need, instead of giving the whole blood to the person or the patient. Okay, so what are the cellular components? You know the red cells. We have the red cells. We have leukocyte reduced red cells. We have platelet concentrate. You must have heard about platelet being transfused during dengue when the person has thrombocytopenia. You have to transfuse the patient if the patient is actively bleeding, because the patient will just bleed to death. Okay, so that is the need for such of this cellular components of the blood, so that they are given to the person which is in need, rather than giving the whole blood. We can have leukocyte reduced platelet concentrate. We can have platelet apheresis or granulocyte cells. We can have of this. Along with that, plasma component, what are they? We can have fresh frozen plasma, single donor plasma, cryoprecipitate, and cryoplasma. This will be discussed later on. The use also, it's coming in the subsequent slide. Okay, the plasma derivatives, we can have albumin, plasma protein fractions, we can have factor 4 concentrate, immunoglobulin, fibrinogen, and other coagulation factors, depending on which factor the patient is deficient, and be given to them. Okay, how do you prepare this in blood group? In Loknayak also, we have a special machine to make this preparation, in which the person is bled at one point, and then it is transferred, and then depending on the specific gravity of each cellular component, the heaviest being your red cell. So depending on that, we separate out the cells. So this is a pictorial depiction of what has happened in cellular separation. We have the whole blood. I don't know if any one of you have donated blood or not. If you donate, they usually check your HB, your weight. Depending on that, if your weight is more than 50 and HB is more than 12, what you usually do is they uh, bleed you. Okay. Along with these two are the empty bags which is there when the person is bleeding in the blood bank. Okay, so this is what is provided after bleeding the person. You take out the blood, and what you do is the whole blood will be satellite. These three empty bags are known as satellite bags. They are centrifuged at a light spin. As I've said, the red cells they are uh, they are the heavier. So the red cell will settle here, and the platelet and the plasma rich platelet will be at the top when you centrifuge it. So what happens is that the person gently presses it, and this is removed. The arrow here depicts the removal of the platelet rich plasma. And when it is removed, what happens next step is this one. Okay. So this is what after you remove it, the arrow depicts it. So after you remove it, the solvent which is present in the other solid is AS1 salt. It is then put into the red cells and this gets detached. So the first component that you get is your red cell concentrate and which is also uh, which is detached. After this, you have the platelet-rich plasma. Platelet-rich plasma is again spinned, centrifuge, and you have the platelet settles down. The plasma is at the top. So you express it out to the other container, and the next container, which is rich with platelet, is now sealed off. So this is a process which occurs continuously, and it has to be done after the person is bled. So after this, we have the fresh frozen plasma or the cryoprecipitated plasma. Okay, this is what you have to know. That is how you separate from one whole bag into its component as red cells, as platelets, as fresh frozen plasma, or your cryoprecipitate. Okay, this is a depiction of what I have shown in the picture before. You give a light spin to the whole blood. You have the packed red cell, which was disconnected. In this, we can have washed red cells, frozen red cells, or these are just red cells. In the platelet-rich plasma, we have the platelet concentrate and the plasma, and from the plasma, you have the fresh frozen plasma and the cryoprecipitate. This is how you separate the components of the whole blood, which was taken out from the person. This is another depiction. I won't go much into this. Okay, this is what I was talking about, telling you about. We have the packed red cells and we have the platelets and the plasma. Okay, if any other bag is there, you have the cryoprecipitate. Okay, these are the packed red cells. This is the platelets and the plasma. Okay. Various blood banks have different bags in them. They can be triple bag system in which we have the red cell, platelets, concentrate, and the fresh frozen plasma like the previous one which I have shown. They can be quadripeg of that four in which we have red cell, platelet concentrate, cryoprecipitate, and cryopoplasma, or double bag system in which we have only the red cells and the plasma. Along with that, we have some preservative. This storage also reduces, this work glucose is needed for this. How do we preserve such cell for durations of 42 days or 4 days in place of the platelets? How do we do that? We put some preservatives in the bags which we are storing the blood as citrate dextrose or citrate phosphate dextrose, which can be stored for 21 days, or you add citrate phosphate dextrose with adenine to store it for 35 days. These are the additives which are packed in the bags as a preservatives, which saves the or stores the blood for longer duration. Okay, this is the anticoagulant preservative composition which is used and for the storage limit, which can be there. Okay, depending on this, what are the role of it? For dextrose, we support ATP generation, adenine, substrate for ATP synthesis, citrate, you prevent coagulation of the by chelating calcium, sodium bisphosphonate prevents excessive decrease in pH. Mannitol is also used. We can have other preservatives, and the limitation on the days for which it can be used is there. Okay, so this is just a depiction of what all components which we have and where all they can be used. We can have cryoprecipitate to treat fibrinogen deficiency. We can have concentrates of platelets to prevent bleeding or low platelet level. This is mainly used during dengue time. Fresh frozen plasma to correct coagulation factors or plasma loss from burns, and RBCs to treat the anemias. Okay. So, what is the importance? Why do we need to separate out the whole blood as components? What is the advantage or the disadvantage of this? So, specific components can be administered, allowing several patients to benefit from one donation. You have seen from one bag, it was separated into four or three, depending on which bag was provided at the blood bank. So, it can be separated out. We give the red cells to the anemic patients. We give FFP to platelets to the person who is having thrombocytopenia, and the other fractions depending on what the person is having deficient it or the cryoprecipitate or the coagulation factors. So administration of unnecessary or unwanted component is avoided. Why should we give plasma to a person who is just anemic? So we remove out the plasma so that we give only the red cell, packed red cells. Storage requirement differ for different components. Okay, they have to be stored and at different parts. We have to store the playlist. My resident will be showing you how the playlist, how each component is actually stored in the Lok Nayak hospital. So this is different. So you can't just put it in one bag and keep it like that, because all the cell constituents have different storage temperature. What is the disadvantage? uh, Massive transfusion of multiple components, they are more expensive and more difficult to transfuse than whole blood, and you need all these equipments to segregate for the storage also. Exposure to infectious complication increases, number of donor exposure increases because we're taking from different donors and then transfusing it to the patient. This is how the storage occurs in different labs or in the blood bank, in how it's there, how the platelet is stored. This will be discussed again during practical, so I won't go into it. So blood component, this is the storage temperature and the shelf life. How do you store? This is frequently asked. Please read it. I'll rush a bit because I don't have much time now. Okay. Now, what is the use of such blood components? Okay, so for the whole blood, we have increases the red cell and the plasma volume in all this road traffic. So with massive blood, you usually give whole blood. Okay, red cells increases the red cell mass, and you transfuse this in patients with severe anemia. Okay, leukocyte reduced if the patient is having febrile non-hemolytic transfusion reactions, or to reduce the CME transmission. We can use wash red cells also if the patient is having allergic reaction. Then we can have platelet concentrate, as I have told you before, during thrombocytopenia and cryoprecipitate, depending on the we can have in hemophilia A, 1 milligram deficient. A brief word about apheresis. It is to separate or remove the particular component of the blood from the donor, and the rest is moved back inside into the uh, donor. So you separate out plasma or you separate out red cell. The rest of the component is then returned into the individual. You do not bleed the whole blood, but rather one component, and the later is returned to the individual. That is apheresis. Okay, so World Blood Donation Day is June 14, and it's coming soon. Okay. Now, pre-transfusion testing. These are some of the tests. This will be covered in practical, so I won't go much into this. You have to test the before a transfusion is being given to a recipient, you have to test the donor cells as well as the recipient. Both has to be tested. And at times, what is important is the cross matching, which will be dealt in practice. Okay, you have to identify the recipient blood sample, and checking of the previous record is also needed if the person is getting repeated transfusion or if the person is having a reaction. If the person has had a previous reaction, you have to think of other methods of transfusing, like wash red cells if the person has been having reactions previously to a transfused packed red cells. Okay, so this is what is needed before transfusing. Okay, cross match is what you do before transfusing to the patient. So you cross match a donor's blood group with the recipient to know what if actually this is what is needed for that. So cross match and blood grouping is different. Blood grouping is you know just what the person is having as A, B, or O blood group. In cross match, you are matching the donors and the recipient blood group. Okay. This I'll not do because this is done later. Okay. Transfusion reactions. This has been covered exhaustively by my resident. I'll just touch on it, but and he has around 4 5 cases on this, so I'll just touch on the transfusion reactions so that I can cover the other two topics which are remaining. Okay. So the classical history which he will be sharing with you, so I'll not go into this. What I would like to tell you at this stage is the why is there how common is transfusion reaction. It is very common, and despite all the tests which we do at every level, it happens. Okay, it can be very mild or it can be severe. It's classified as acute or delayed reactions. Acute is immediately within 24 hours, or delayed more than 24 hours. So, what are the signs of transfusion reaction? This is clinically important when you become an intern. When you are intern and posted in the ward, you should know what is the required thing at your level or at the stage when you're seeing a patient with transfusion reaction. Okay? Patient usually complains to you with fever, chills, and rigor. These are usually very common. Okay, at times they may come to you with respiratory distress. There can be hypertension or hypotension, pain abdomen. It's mainly near the lower abdominal. They can be at the chest, flank, or back. Can be there. The patient may complain pain at the infusion sites also. There can be urticaria, rash, flushing, or edema, jaundice. It can be many, but the most common is fever, chills, and rigor. Okay. As I've said before, it can be acute or delayed. Among the acute, we have uh, hemolytic, febrile non-hemolytic, allergic, anaphylactic, and transfusion-associated acute lung injury. This will all be discussed in 2 to 3 time. He has exhaustively made on this, and delayed can be any of this. And graft versus host disease, it has been done during your immunity. Okay, so non-mediated immune-mediated reactions can be acute or delayed, just like in immune-mediated. In acute, bacterial contamination can be seen in the blood bag itself, which is leading on to sepsis. There can be circulatory overload. There is physical damage to the red cell, which is leading on to hypokalemia. Or there can be iron overload here, hemocytosis, and citrate toxicity. As the bags contain citrate, there can be citrate toxicity. Okay. I won't go into this because this has all been covered by my video. Okay. Okay. Lab investigation. What is at your stage? What you can do is stop the transfusion and inform your senior. That is what I will say. At an internship level, this is what you have to just stop it and check it immediately. Inform your senior, and you have to check all the labels. You have to immediately, the sample has to be taken from the patient and that from the blood bag. It has to be sampled out. You have to take the urine sample from the patient, and you have to take pre and post transfusion evidence of free hemoglobin increase. You have to do a DCT or DCT on that. You have to take the haptoglobulin levels. Okay, I'm rushing on this because this has been covered from 2 to 3. This is the picture which I wanted to cover. Okay, I don't think it is there. So, what is at your level? What you do when there is a transfusion reaction? You stop the transfusion. You inform the your senior, perform clinical check and see. You do a hemoglobin, you do the haptoglobin level, you do a cross matching of this patient, you do the direct Coombs test of this and ABO testing. After that, you do all these tests. You do for haptoglobin, LDH, urine hemoglobin, and you evaluate and see what level the process has gone wrong. Okay, so febrile non-hemolytic transfusion reaction is very common. It is because of this also I'll not go because this is all dealt in your transfusion. TACO is also there. He has dealt with TRALI also, TACO also, hemosiderin and hemosiderosis and graft versus host disease. This all cases, I don't think that I'm rushing because of this. He will deal on this. I do not have much time. What I wanted to cover is transfusion transmitted diseases. Okay, transfusion transmitted diseases. This comes as a most commonly as a short note. Okay, they can be the transfusion which it is at the bank. You usually check for at various level for HIV, HB virus, hepatitis C, malaria, and for syphilis. This is checked, but at times it can be there. So initially we have a list of all the infections which can be transmitted. This is the virus, that is hepatitis B, hepatitis C, hepatitis D, A, HIV, and CMV because of the WBC. These are the list of the viruses which can be transmitted by it. Initially, by around 1980s, hepatitis B, C, and HIV, they are not usually screened. After this, it was all screened. If you know of some famous person, Amitabh Bachchan, usually had got hepatitis because the blood which he got when he got injured while shooting off a film was because of this blood transfusion which he got, that is hepatitis B virus. It now, as a routine, when any donor comes, these are all screened at various levels. Okay, I know in our lab also we do nucleic amplification tests even for HIV. Okay, these are the viruses. Along with the viruses, what are the bacteria which can be transmitted? We can have Treponema pallidum, which causes this. Then we can have Staphylococcus epidermidis, Staphylococcus aureus. The list is endless. Okay. Along with the bacteria, what we can have is the parasite, malaria. Malaria screening is done in our lab, in blood bank to screen if the blood donor has malaria or not. So these are the list of the virus, the bacteria, and the parasite which is transmissible if a person gets transfused with blood. So checks at various level is done. However, reactions do occur, which can be because of the many things which I have said, which can be because of febrile non-hemolytic transfusion reactions or because of some minor cross match. Okay. So mandatory screening for blood donation in India, we have surface hepatitis B antigen, which is done here also for HIV, hepatitis C, and BDRL we do, and we have blood screening for malaria. Then see some of the meantime infections for seroconversion for HIV and HV, which can be there if it's in the window period. This is all about microbiology, the range to which they mean infection and seroconversion, which can be missed times if it's in mainly in the window period. Okay. So malaria and Treponema pallidum, this is the seroconversion and through which the person can be detected if in case this. As I've said before, this is a addition which I have never taken probably before. I used to say it only when we had discussed blood transfusion. Now I have to say it A special type of blood connection is autologous donation. What we have, they are what we, as the name suggests, means the person donates their self blood and it is then infused into them. That is all about autologous donation. There are several types of autologous donation. Okay, so the voluntary donations, which the person, what happens in the blood bank is they donate, then it's given to the other person. If you have ever gone to a blood bank, they ask, usually ask for a relative to bleed because they have to replace it for the other person who is going to come. This is actually allogenic. The person's blood group is being given to someone else. Okay, so in autologous, what happens is that the donor's own blood is used later. It is stored, whether it is bled in times before and used during surgery. It's there. What is the risk importance of this is that risk of disease transmission, transfusion reaction is all less because you're receiving, the person is receiving his own blood. Okay, so this is all, transfusion reactions are all significantly reduced. Three general types of autologous procedures. They are perioperative collections before the operations, normovolic hemodilution, and blood recovery. These are the three main things which has been described in autologous transfusion. In preoperative autologous donation, this is the most common type which and necessitates careful tracking and handling. Out of the three, this is the most common. That is pre-operative collection. Before the operation, the blood is collected in the blood bank and then transfused during surgery. So what happens in the most common type, that is your pre-operative collection, is that blood is drawn and stored before the anticipated transfusion and is used for stable patient which is scheduled for surgical procedure. Okay, so if a person is having perforation abdomen, you can't use it in them. This has to be planned surgical procedure and the patient is stable. Okay, this is useful for rare patients with rare antibodies that make cross-matching allogenic units very difficult and do not allow allogenic transfusion. Some have a very staunch belief, religious belief that they can't be transfused someone's blood. Okay, so in such patients, what you do is that you collect the blood in advance. You operate the patient, and if blood is needed, to transfuse it there and then. Okay, patients being treated for bacteremia are ineligible for autologous donors because the bacteria will persist in the blood which is taken and it will not be of any use. That was about preoperative autologous transfusion. In normal volumic hemodilution, what you do is you remove one or more unit of blood and you replace them with crystalloid or colloid solution so that the person does not land with hypotension. So you bleed and then replace it with them. The blood is stored for reinfusion during or at the end of the surgery. It is referred to as acute normovolumic hemodilution. The blood recovery, which is the third type, in this, what is that? The blood is collected during the time of surgery and then reinfused. That you need to have specific instruments to or some machines to purify this blood and then transfuse it in there. So a medical device is used to collect shed blood from the operative blood field. The process has collecting and directly reinfusing at the time of the operation. The downside of this, it does not remove the bacteria, okay, and it's not useful if there is any bacterial contamination. So these are the advantage and disadvantage of autologous donation. Advantage is prevention of transmission transmitted diseases, prevention of alloimmunization, supplementation of blood supply, prevention of febrile and allergic reactions, and reassurance to the patients. As I've said, who has a strong belief that they can't be transfused with any other blood. Disadvantage are inventory control, preoperative anemia. If the patient is bled, the patient will end up with anemia. The cost for storage, for bleeding, and the machine which is needed. There is a high wastage, and chances of high wastage is also there, and increased incidence of adverse reactions to donation because the patient will end up with bleeding from his own blood. So, as this, we with the preoperative anemia or adverse reaction due to donation as such. That's it all about today. Um the transfusion reaction, I have not covered much because